Welcome everybody to the January 17th, 2024 Health and Human Services Committee meeting. Are there any changes to the agenda? Are there any public comments? No, thank you. For the chair's report, I just wanted to say thank you. It's been a pleasure to work with this group. It's been mostly the same group for the last 2 years, and I think we've covered a lot of ground. I feel like 2 years ago there was a newer crop of legislators, and so we kind of kept things on the surface, that was my goal at least for the year, kind of an overview of a bunch of different issues and departments. And then, I don't know, I'm not sure if I shifted out of that mode into the second year, but my sense going forward is that maybe the committee is going to try to dive a little deeper into some issues, now that you've been more than well exposed to all the things the county does. So thank you, everybody. All right, County Administrator's report. Bridget?
Thank you. Just a couple items of note. I thought it was important to note for the committee and the public that the issue of addressing homelessness as well as expanding our shelter capacity, that conversation is largely occurring in the Housing and Economic Development Committee. However, as you're all aware, many of the departments that report to this committee would be somehow involved in providing services. Environmental health, for example, may have a role to play. So I just wanted to make that note. There's many parallel conversations occurring, and it will be important to bring in departments across the committees to make sure we're all on the same page. And then somewhat related to that, we are planning to convene with our partners for the outreach worker program. As you may recall, the legislature authorized funding for what was formerly the Rural Outreach Worker Program. And we've combined that funding with the funding that came from our partners at the Downtown Ithaca Alliance and the City of Ithaca for what was formerly the Community Outreach Worker Program. So those are now combined into one pot of funding, and we're working with our partners to issue the RFP, hopefully in early February. That will be going out. So if anyone has any questions on that, I'm happy to address them, but that's all I have.
Thank you. Any questions for Bridget? All right, thank you. Okay, well, the next up then is our presentation today. The presentation is on, and I'm learning the new words, supervised consumption facilities. We've got Dr. William Claypack, who is the Tompkins County Medical Director. And why don't you just take it away from here? Thank you.
Well, thank you, and excuse me, good afternoon, and thank you for having me and for having the interest in this topic. It's been 6 years since I was before this committee and gave you an update on the situation at that time, and quite a bit has happened, and I think you'll find it quite interesting. You can see some of the terminology has evolved. And so typically I'll be talking about what it's called opioid prevention centers. I want to start with some photos because there are many misconceptions about what these centers are. And they aren't flop houses or crack dens or other sorts of things. They look a lot more like a clinical setting, a clinical operation. And you can see here in the photo sterile supplies sitting out, ready to be used, ready to be dispensed, and cubicles in which when people are consuming a drug or they will use these for that purpose. They also can provide a testing site for people to bring in drugs that they bring in from outside. No drugs are dispensed in the centers. And those outside drugs can be checked for certain substances to the extent that it's able to do so. That can serve an educational role I'll get into later. The clients who come in to use these centers have a clean, sterile surface to use. The mirror that you see there is for the purpose of staff to be able to monitor them and ensure their safety. And I want to underscore that one of the major features of these centers is the relationships that are created between staff and client. And you'll see why that's so important as we go along. I'm given to understand that the concept of harm reduction is something you're very familiar with. I won't go into that in detail, but we will go through the operations of these centers and how they function. And why we're here is clearly demonstrated by our data from our vital statistics section of the Department of Whole Health, and what has occurred from 2012 to 2023, with overdose deaths going up about nearly 2.5 times. As far as it goes, I have no conflicts of interest. I do want to underscore that the opinions I'm expressing to you this afternoon are my own, not necessarily those of Whole Health, but I'm glad to say that I've had a conversation with Frank, our public health director, and he continues to support the concept of opioid prevention centers. And I want to thank the research assistance of Francesca Pertl, who is with me this afternoon. Frankie is one of our public health fellows and helped to do some of the data research with me. And then I collaborated, of course, with partners in our region. So we'll talk about the overview of the centers, the global experience, the U.S. initiatives, but particularly the New York City experience. We'll talk about our environment and some attention to opportunities and challenges and the economics of a center. So they are a sanctioned function, a sanctioned service. They're supervised. The drugs are not provided at the center. They are brought in by clients, and the staff are key. They are trained in harm reduction, overdose care, creating relationships, and helping to connect clients to services that can change their life when their client is ready. They coordinate with a wider network of community services in order to make referrals possible and for warm handoffs. And they are a movement away from the law enforcement model. They provide a location where if someone overdoses with those drugs, they can be emergently addressed and they can prevent death or organ damage. And they do practice the policy of using assessment, using the model of the 5 A's, well established in counseling. They do provide a portal to medically assisted treatment. I've listed 2 drugs here which are very important in terms of opioids, but there are many others that are important for other substances. And they are key in identifying and treating infectious disease. You see here numbers reflecting the annual cost to the United States of hepatitis C, HIV, and hepatitis B. 56% of all new hepatitis C cases, 11% of all HIV cases come from injecting drug users. Just in our region, in the fall of this past year, 9 new HIV cases resulted from the sharing of injection equipment. I'll show you the costs of that later. Other conditions are skin and soft tissue infections, sepsis, which is bacterial or viral infection of the blood, heart valve infections, the heart's not immune. All of these require very expensive hospitalization, surgery sometimes, and specialized services. And through OPCs and harm reduction, we are able to cut back on the health care that these individuals would require. It's also reduced by a reduction in the reuse of syringes and needles and in hurry-up injections, which, as you see here, cause less than sanitary situations and are more likely to lead to infections and injury. They are a portal to people getting to detox And in Ithaca, that would be the detox center being created by the Alcoholism and Drug Council on Trip Hammer Road, which, because of staffing issues, is currently functioning at the stabilization level rather than full detox services. And education. Education is, I think, very, very important here. In fact, what happens there is more important in some ways than in the consumption room itself. Trends in street drugs, the risks of using them, it's education given to the clients, as well as the medical risks, the infection risks, the opportunities for abstinence support, mental health counseling, housing, etc., all of which can facilitate a person making a change. But not all clients are ready to change, and continuing care is important. And that's what staff provides. A continuing knowledge of that person, a personal relationship, ready to help them when they are ready, continually reassessing readiness to change, and recognition that not all will change, but that harm can be reduced by their actions. So a portal to also abstinence-based treatment. In Vancouver, BC, initially with Insight getting started up there many years ago, there was some pushback from abstinence providers. But as time went by and they became familiar with what was going on, they became allies of the program. More than half the individuals at New York City On Point are getting additional support during their visit, which extends beyond the use of naloxone or counseling or medical care and into the community. The entry into treatment is correlated with weekly use of such centers, correlated with the contact with their counselors, and strongly associated. The more heavily the use of the center, the more entry into treatment can occur. Analyses suggest that the amenities within the facility are responsible for increased uptake of addiction treatment among clients. So what is the global experience? Well, we have now over 53 years of experience, with the first site being started 53 years ago. Now 200 plus facilities worldwide, over 66 cities, 12 countries. In Canada, in North America, Canada has the lion's share, of course, and in the United States we have 2, run in New York City by On Point, with over 90,000 encounters by over 4,000 individuals and over 1,100 overdoses, no deaths. And no deaths actually worldwide. The data collection, at least 3 of these centers were set up to intentionally collect data. You see them listed here, and many other sites across the world have published data. The experience globally, you can see for yourself that these particular sites, and there are many more, have a tremendous number of injection experiences, a great number of overdoses, and no fatalities in any of the sites. There was only 1 death associated at all, and that was due to an anaphylactic shock episode back in 2002, which was not related to the overdose per se, but due to an allergic reaction. The community impact has been well documented. Insight in Vancouver, a 35% reduction in fatal overdoses in the area around the program site, outside of the program, a reduction in overdoses. And On Point in New York City found reductions in 911 calls generally in the area around the 2 sites that they operate. So what is the experience in setting up these centers if narcotics are illegal? Well, I would say generally, globally, that each society has found a way to allow for their operation when it had motivation to do so. As of March 2022, as reported by NPR, Despite winning the Philadelphia lawsuit case, the U.S. Justice Department indicated that it might stop fighting such sites, saying it was evaluating them and discussing appropriate guardrails. On point, status as of today is that after consultation and careful collaboration at all levels of jurisdiction with prosecutors and law enforcement, they were led to an understanding that, excuse me, while laws exist, which if enforced would prohibit it, they would not prosecute or interfere with a center's normal operations. So why move away from the war on drugs, the law enforcement model? Well, I think I probably don't need to tell you too much about this. There's been much discussion about the failures and the minimal impacts that it has had. It's been frustrating for all levels of our Justice Department, justice system, and law enforcement, and we haven't particularly succeeded with it, getting people into abstinence and into a better place. Various jurisdictions have had endorsements from their sheriffs, their chiefs of police, their high courts, etc. And as I mentioned in New York City, no increase in crime in the region of the SIFs. In fact, an 83% reduction in drug arrests, and not only 911, but 311 calls decreased compared to the rest of the city. In the community, generally, noise is reduced, public injection and injection litter are reduced, and injectors, clients don't tend to come from outside the general community. And support generally increased over time from the public. New York City's experience has been similar to date, and notably they've played a major role in helping with hazardous litter. Medical societies of many stripes have come out in support of the centers, and the creation of the OPCs, as I probably don't need to remind you at all, requires cooperation and collaboration on the part of major sectors of our society. So who does use these centers, and who are they best aimed for? And there's some of our most disadvantaged people, some of our homeless, borderline housed. They tend to be in this 20 to 50-year-old age group. They tend to be male. Here you can see Klein characteristics globally, which confirm this. And from studies looking at the habits of clients using these centers, they're 2.5 almost times likely to be homeless. They probably are using heroin or cocaine. They're not on a methadone program. They may well have been involved in the sex trade in the last 6 months. But they also tend to be fairly consistent users of the center. They're twice as likely not to reuse syringes. They're almost 3 times as likely to be less rushed in doing an injection or inject outdoors in public spaces or in a corner. They're far more likely to be doing it in a more appropriate manner due to that education I mentioned. And their techniques tend to be generally in favor of minimizing, reducing medical complications. They have never been proposed as a panacea. They won't cure our problem totally, but they will keep people alive. But other strategies obviously remain very important, and we must not lose sight of that. So let's look at a little of the US and a lot of New York City. Canada, our nearest neighbor, is running in excess of 38 opioid prevention centers. Seattle is endorsing a couple of sites. San Francisco and Baltimore are considering sites. You know that Philadelphia was trying to get one off the ground. Vermont, Rhode Island, New Jersey, also considering sites. If we look at New York City data from On Point in the first full year of operating, their demographics tend to confirm the global experience. Their utilization was 48,500 visits. They had 2,800 plus unique participants. They intervened 636 times to prevent death or harm, about 1.3% of utilizations. 83% of the overdoses were resolved without the need of naloxone by virtue of skilled knowledge on the part of the staff, prompt and quick response, use of oxygen, and stimulation and other measures. They generally were involving opioids. Some folks use crack, and obviously other substances are also used. More than 75% of them used and accessed wraparound services. 20% were referred to other services or needs such as housing. And 100% of them who wanted to go to detox or inpatient treatment were connected to outside providers. Of that 48,500 utilizations, EMS was called 23 times. Or in other words, 3.6 of all interventions, that 636 number that I gave you. The users, the clients and the centers averted public drug use in 81% of visits. And through the actions of On Point, not only by diverting usage into the center, but also by going out and actually picking up waste, a tremendous number of waste has been removed. Here's the age breakdown for On Point, confirming the global experience. And as you can see here, most people are either homeless or in shelters, hostels, etc. Currently, there is pressure being put on Governor Hochul. Recently, 111 New York State organizations have asked her to allow the use of opioid settlement funds to fund overdose prevention centers, of which I'm given to understand there's $2.6 billion. 13,000 New Yorkers have died from preventable overdose, and numbers are trending up. So here we are in Tompkins County. Are we much different or are we much the same? And I guess you know probably we're a little of both, right? What would the balance sheet for a facility look like? What would the profit and loss look like? Well, we'd need to have knowledge of the volume of visits. We'd need to know in absolute numbers how many overdoses we prevented and how many diseases that we either prevented or reduced, so that we could attach a dollar figure to those numbers. Unfortunately, rural data for our country is lacking. The practical considerations are, of course, how many staff would we need to staff such a place? You don't need a lot of doctors to run something like this. You do need some nurses. You need some very skilled, trained staffers to render care. What would be the scope of services? And then, of course, all the other costs that you have to figure in. The strengths that are perceived for our region by me and some others are that the public understanding of harm reduction has come along in the recent years, and some would say has significantly improved. So perhaps the bar for a center is not as high as it might have been a few years ago. Law enforcement and prosecution have had experiences that might make a center more feasible. The various projects, the discussions that we've had in recent years, the evolving framework for law enforcement activities. And then we have New York City's experience to say, that's pretty close to us. It is a big city, but that's some relevant experience. The opportunities are that while it's still technically illegal, we do have some precedent that we might go forward with. We have significant partners in our region who are in favor. And we have some ancillary benefits of a facility which could host a variety of services that would benefit not only clients, but the community in general. But there's fundraising. Where do we get the money? How do we staff it? Given that the detox center is having trouble staffing, given that healthcare generally is having trouble staffing, and given that in general, retail, et cetera, is. And there's certain to be some public pushback. And that debate and public discussion, of course, is always key. But the steps to do it is to go forward, confirming buy-in from partners, have those discussions with the important partners in the community, have visits to places, to On Point, for example, to dispel misconceptions. And should a site ever get started here, to do that here as well. And what about staffing? Well, I can't believe that this is going to go on forever. And I do believe that we should be poised to take advantage of the opportunity when it arises. And funding, I think, should be informed by the economics of the center, which I want to get into. If we were to set up a center like this, we should plan to collect data. We would be the first rural center of this type, certainly within the United States, and collaborating with academia would add important data that could benefit many communities around the country. Well, what are the economics? Well, let's first step back and acknowledge the inability to attach a monetary number to life. These are lives that come from all sectors of our socioeconomic world. These are people, some of whom we've known. I can't imagine that there are many among us who haven't been afflicted with experience within their family or friends or an associate or some other connection where someone died from an overdose or their life was threatened by one. But we could start with some assumptions. And one assumption is that there would be about 400 unique clients using such a Tompkins County facility. And that if we use New York City data to ballpark the Tompkins County experience, we can attach some numbers. And we can use staff's experience with the syringe exchange program to inform us also. So I'm not going to ask you to read all these words. I've provided this PowerPoint to Dan, and I encourage any sharing that you wish to do, and I particularly would be interested in feedback. But using the assumptions I listed, we know that On Point averaged about 17 visits per client per annum. And I would project that Tompkins County Center visits would come to about 6,800 plus, or about 18 to 19 per 24 hours. On Point had 636 interventions, and if we extrapolate to Tompkins County, that would be about 90 interventions per annum. That means actually intervening to save life or to mitigate harm, about 7.5 times per month. On Point called EMS 23 times. For Tompkins County, that would come down to being about 3.2 EMS calls per annum, a reduction of about 96%. So to express this in approximate dollars, we have to look at costs. And we have to start by saying we know that EMS ambulance considerations play here. That ambulance groups have dropped in number in the region over the past years. Response times have been a challenge to keep low, and costs to municipalities have been a concern. Here from a recent report are ambulance spending in our county, 2011 to 2021. And if we look at overdose calls for Ithaca, they rank 6th in number, and for non-Ithaca, 12th. Not insignificant numbers of calls for these people to handle. When we look at what EMS call costs as a component of healthcare dollars that can be saved, we have to look at base charges, additional charges if life-saving interventions are needed, emergency room charges, because every EMS run is going to result in an emergency room visit, and then any hospital charges. So a base rate for ambulance is about $1,300. If it rises to the level of advanced life support, that $1,300 becomes $1,600. Mileage is said to be negligible. If a client refuses transport, there is a charge. And if one runs the numbers through here, you come out to a potential savings in avoided trips of $138,000 plus per annum. If we look at emergency room and hospital costs, the base rate, when you look on the web for 2017, is $600 to $1,000. So if we take a midpoint of $750, and then we say, well, there's definitely going to be labs, oxygen, drugs, that'll probably get another $800 or more. Most overdoses require observation. Some may rise to needing an ICU. It'd be conservative, I think, to add 1,200. And since I'm talking 2017, we can bet 2024 is significantly higher. But if we run these numbers through, we come to a bottom line for hospital, ER, and in-hospital of likely a minimum $274,000 plus dollars. And if we add these all together, we come up with something like $412,677, and again, I think this is a minimum. Global data shows that these centers generally incur net negative costs and increase client life. If we look at other costs that our society is bearing, and I know you realize that these are mostly borne by insurances, but also by tax dollars supporting our tax-supported healthcare systems of Medicaid. And so we look at HIV, $400,000 per case. If we look at those 9 cases from the fall, that comes to $3,600,000. Hepatitis C costs $25,000 to cure an individual. We had 5 in Tompkins County in 2023. That's a total of $125,000. Not all of those for Tompkins County may be people using substances. We would have to drill in to see. Endocarditis, it's a heart problem, $100,000 per case minimum. And then we have other expenses. So I would say it's an expensive proposition not to have a center. There's good global data to support them. There's nothing inherently different from New York City data now about the United States compared to what the globe has been seeing for years. Additional, especially rural OPCs are needed, not only to save lives and reduce disease, but to provide further data about efficacy and scalability. How does it scale when you're moving from one community of one size to another of another? I think the political reactions to the centers resemble what we saw with syringe exchange programs so many years ago, and the global data has shown both of these, syringe exchanges and centers, to be a success story, I would submit. But I would also say that the most important things happening in a center are not happening in the consumption room itself. It's happening with the staff. It's happening with the harm reduction education. It's happening with the referrals. It's happening with the interventions. It's happening by trust being created between people who often don't have people to trust and who need them. And it's so beneficial to have the ear of someone you trust when you need to make a change. Thank you very much.
Thank you. That is a very, interesting, challenging, inspiring topic. Jordan disappeared. Okay. Well, we will get the PowerPoint to everybody. That was, make sure that, to let you know that. Let's just start with questions. Questions or comments? Amanda.
Yeah, thank you. That was very informative, and I mean, I haven't really heard much about it, as you said, in numerous years, so it's good to get all this information. I guess, you know, what you just said there at the end about having a place where people feel like they can trust. I mean, how do you sell this to the client? How do you get them to come in and say, this is a safe place where you can go and do this, and you will have people to trust, and we will help take care of you? How do you, I don't know, how do you get people into it?
I think it starts at a lot of these centers. The staff, many of the staff staffing them may have history in substance use, speak the language, understand what's going on. Of course, there's outreach. You know, the outreach. When I say outreach, I have to think of Project Reach in our own community. You go out. You know, you spread the word. You know, folks don't want to die, and overdosing is a threat they know of, and so I think that in good share is something that would lead you into wanting to be in here. A lot of it, of course, has to be confidence that it's not just a trap. I'm not going to get arrested. I'm not going to be harassed, etc. And that's where, you know, a lot of community discussion has to occur well ahead of time.
Yeah, that makes sense. Thank you. And then another question, more, I don't know if you have an answer, but it's interesting that many more of the users are men than women. Is that because, why do you think that would be?
Frankly, I don't know. I don't know.
Okay, good answer. Thank you.
Other questions or comments? Susan?
I found that interesting too, Amanda, why more men than women. But I also wondered, this is really helpful, interesting, very educational. How do you go about engaging community partners with a program like this? Because I think there would be a need for a lot of community partners and organizations in order to get the word out in education.
No, I think you do it by doing presentations like this. I think you do it by accurately portraying the data. Fortunately, we're the beneficiaries of a lot of data, not only in other countries, but now in the city. And encouraging cross-fertilization, counterparts speaking with counterparts. You know, where one individual can speak the same language between, you know, whatever sphere that they're in, whether it's law enforcement or therapy or abstinence treatment or whatever it happens to be. So getting out there and talking about it and putting the idea forward. Having accurate media coverage. And then I think various municipalities, their various boards and so on should be very interested in what does this mean for us? If typically these centers tend to be located more in a more urban place than a suburban place, et cetera, and so on. You know, you can imagine that if you were to have such a center, it might well be within the city somewhere. So what does it mean to Dryden, Dryden Village, which struggles with substance use related issues out there? Will it help them? How will it help them? Will it help them? How far will people go in a more rural setting like ours to access a center? If you look at the data from Vancouver, BC, for example, it's generally a 10-minute walk that people will come. But you're in a city, right? And it's a very different kind of thing. If I'm in a nearby village, if I'm out in Dryden, am I likely to come in and use it? These are questions that need answers, and we may not know the answers exactly before we actually have an example that we can study.
Randy?
Yeah, I learned quite a bit. Thank you. Seems like I've been reading about ingestion sites for a long time in Ithaca. I found it interesting, too, that in your data that it looked like over half of the people were homeless. And I've got different categories, but looking at that would be interesting. I know in the county where Bangor, Maine is, they have 2 shelters. They have a dry shelter and a wet shelter. In the wet shelter, they let people inject, but they don't supervise. And maybe that's how they get around that term where they're not allowing anybody, but it's a wet shelter, so people who are still using drugs can use drugs there. So that was really interesting. There's an article about that, but very interesting. Thank you.
Do you think in Maine it's, I didn't see it, so I don't know about it for the facility?
It's called, it's in Bangor, but it's for that county, and I forget what it's called. But they call it a wet shelter. And so it's a place where people can use drugs, but they can't go in the dry shelter, for example. So they separated the groups. And so the treatment for people using drugs still is, made for that population of people for where they want to do methadone or whatever. I think it's also a methadone clinic, I think is also in the same area, so. You can Google, you'll find it.
Yes, I'm sure.
Yeah.
Thank you.
Travis.
During the presentation, which was great, you talked about data throughout the presentation. Can you stress the importance of data-driven results? Can you stress the importance of, well, it seemed like you did during the presentation. I found in a lot of these discussions, folks are still talking about solutions that have proven not to work over the years and are reluctant to move off of these ideas, even though the data informs us that these things have a 12% success rate, a 20% success rate. These have an 80%. We're keeping people alive through harm reduction and actually getting them to a place where they can you just really, for folks that are listening, talk about the importance of evidence-based, data-based programs?
Yeah, I couldn't agree with you more. Sometimes we have the data that helps us, and sometimes we need more data. We don't always have the data we would really love to have. But there's so many misconceptions about people who have substance use disorder, who they are, what they're like, et cetera, et cetera. I think that if nothing else, this terrible epidemic of overdoses has taught us that these are all walks of life that are afflicted, and that in itself should help us to dispel any disparaging misconceptions we have about the folks who are afflicted with this disorder. And I think the bringing together of the center and then the referrals and having the options of various approaches in front of you as a center staffer provides a platform to debate the evidence behind one approach versus another, and which ones fit best with which types of clients. I certainly don't put myself forward as being an expert in terms of treatment of substance use disorder. I've had a number of different experiences with regards to it. Years ago, when I was a medical student, I was in Ireland, and I was there principally for obstetrics training, but I came across a group called Simon Ireland, S-I-M-O-N, Simon Ireland. And Simon Ireland was running operations in several Irish cities. One of them was Dublin, where I was. And their philosophy was that And in those days, it was primarily alcohol and mental health issues. I frankly am surprised to be able to say that I don't remember coming across anyone, narcotic issues, et cetera. Isn't that surprising? This was about 1971. But Simon Dublin ran 3 different levels. We had a night shelter. We had to come in, at supper time, stay the night, you're out in the morning on the street. Then there was a living arrangement, supervised, staffed, for people who could do that, and then supported apartments. The idea was that if a client could move from one level to another, that's what we would do. But there was always the distinct recognition that some clients may want to change, but it's difficult to impossible. And they may stay at a level. And while they stay, and being that as it may, you support them. You try to keep them healthy, alive, and intervene where you can. So that shaped and has shaped my outlook on life to a great degree. And I think it's very important for us to recognize that we do hope that people would progress from one level to another. But while they're at that, whatever level they are at, and if they're going to be there forever, then at least we want to reduce harm. And that means by reducing harm for them, reducing harm to the community in general.
When I talk to people about the subject, the first most common reaction I get is, that's illegal, right? These aren't authorized. And you touched on that quite a bit in the presentation. But we also have the district attorney here, Matt Van Houten. And I'd be interested, Matt, if you're willing to come up and sit at the table with us. I don't know if you have anything in general you want to say. I guess my question is, what would happen or what has happened if you have come across this kind of activity in Tompkins County?
Well, I can say to start out that it is illegal to possess narcotics in New York State, as it is in most places in the world. We almost never in Tompkins County prosecute people for simple possession of personal use narcotics. That's not to say that they aren't arrested for it, because the police arrest people and then those cases come to my office and we decide what to do in my office with those cases. So we see them come in, and typically what we would like to see is the person engage with treatment, or through lead we try to divert them so they're not in the system at all. But this is a resource that would help keep those people alive, which, in the context of harm reduction is the definition of harm reduction. A center like this would still have the same concerns that we have now in terms of the drug dealers who would remain in business, and that's a focus that we do prosecute in my office, especially because the drug dealers in the last couple of years have been shooting at each other, and that's a danger to the entire community. So the things that relate to the drug world will still not be addressed by this, and they may be focused to some degree more. I mean, I know that there's some data, but I've been to Insight in Vancouver, and I've seen the neighborhood that it's in, and it's scary. And I would submit that the block of State Street where STAP is right now is also scary, not to the extent of Vancouver, but that's a concern that we should all be thinking about. So there's lots of layers to this. The concept of harm reduction, in the sense of the center and whether my office would interfere with it, we don't prosecute, like I said, the people for having their personal use narcotics. So we certainly wouldn't be looking, and I would hope the police wouldn't be looking to find the individuals who would be using the center to, stay as safe as possible. I would hope that wouldn't happen. I don't control the police and what they do with their time, but it's not a valuable use of their time, I think, to focus on low-level drug users as opposed to more public safety-oriented crimes. So I don't know if that answered your question. I mean, I think, it is a multi-layered conversation. It's one that requires the police to be involved and to understand, the dangers of the drug world are not just the use of drugs, it's the sale of drugs and the business of drugs and the violence that comes with drugs and the other crimes that relate to the half of the people that aren't housed, stealing on a regular basis to fund their drug habits, committing other crimes that relate to the maintenance of their lifestyle. So this is a complicated conversation.
Could I ask, Matt, when you visited Insight, my familiarity with the data that came out of there, I think it's correct to say in the general region of Insight and so on, that they saw similar community effects in terms of crime. That is to say, it didn't particularly increase, it didn't particularly make things worse. In fact, some things might have been a bit better. I've driven through that neighborhood too, and it's like very urban, very urbanly scary, as you said. But I think the general community environment issues are similar to what I depicted in the presentation. Would you agree, or do you think?
I don't think that crime has increased, but there was a lot of crime to begin with.
Yeah.
So that's the baseline that you have to work with. It's a dangerous area to begin with. So, if it were to decrease, that would be the goal.
Mm-hmm.
Questions or comments? Well, again, I want to thank you both very much. Thanks you for the presentation, Matt. Thank you for coming and being willing to share with us. We are going to share this presentation around. I will report it out at the next legislature meeting. I do see a reporter here, so, there'll be a little bit of community discussion. Did somebody have?
Yeah. Matt brought up LEAD. I realize we haven't done a presentation to HHS about LEAD, so maybe in 2024, if Sean is not listening, we could, I could bring the staff of LEAD and some of our collaborators and do a presentation so you all can really understand what LEAD is, what LEAD does, how the county plays a role in LEAD, and some of the outcomes we've experienced over the last 3 years. I would love to do that.
Well, just my question is someone proposing to begin this, to try to get something like this started here? Or is this still just sort of an idea, or what? I mean, it's good to have the information, but is someone actively working on it?
I think this is one of those concepts, ideas, and so on. At any point in our life as a government or as an agency or as a department, you have multiple projects. Some are at a more propitious point than others to execute, either for a variety of reasons. And with regard to opioid prevention centers, certain things have fallen into place. We do have one in the United States that's openly operating, sanctioned by the city of New York, et cetera. We do have, therefore, some U.S. experience. And yet are all the other pieces in place. We do have a community, I think, that does understand harm reduction more than perhaps it used to. We do have a greater and greater sense of tragedy with regard to overdoses. So that in terms of that kind of motivation to take a step forward is there. But what about the other pieces? So as I mentioned to you, there's the staffing issue. You can't do anything if you can't hire people. That's going to resolve some point. What are the other pieces that need to fall in place? So I think more than anything else, this is a continued discussion with, on my part at least, some eagerness to see if it can't come into fruition. I guess your question maybe is, who takes the lead on something like this, right? Often it's advocates, agencies, sometimes not-for-profits who say, hey, I'm going to do this.
So who operates the one in New York City?
That's an interesting story. So there were multiple places that were in the running to start a opioid prevention center at the behest of the New York City Department of Health. New York City Department of Health is a big city Department of Health. It predates the New York State Department of Health. It has services that mimic the New York State Department of Health in terms of scope, et cetera, and expertise. They decided they could no longer tolerate the number of deaths that they were seeing, and then something needed to be done. And so they put out, if you will, sort of a request for a proposal. Numerous sites responded, and On Point was one of those. It had previously been operating, as had many of the other applicants, syringe exchange programs. It had a proven track record with the city, with law enforcement, with other branches in the city, and was chosen. They had 2 syringe exchange programs, and both of those they converted to being a full opioid prevention center.
A safe injection site actually is in the city's municipal drug policy that was done, 8, 9, 10 years ago almost. So it was the most controversial part of the policy. It kind of derailed the whole thing because it ended up in the New York Times. But it exists, like a plan to do this within the city actually does exist.
Susan.
I just wanted to follow up. I remember that, Travis, because at the library we talked about that a lot because we used to see a lot of people come in there. What is LEAD as a new legislature? I don't know what that is.
LEAD is Law Enforcement Assisted Diversion. It's a program designed to help. It was originally started in Seattle to help the disparity of folks of color that were caught up in the justice system in regards to crime, social crimes related to mental health, poverty, and addiction. So during the municipal drug policy planning stages, a few of us, including Matt's predecessor, went out to Seattle to look at the program, and then we decided to bring it back to Ithaca. So it started about 3 years ago, and I want to say we have, as of last Friday, there were 45 clients in the program. We contract with Reach Medical to do the outreach. We have 3 full-time caseworkers, a casework manager. We have our partners that meet every other Friday to deal with client services, include folks from Matt's office, IPD, County Mental Health, people from the shelter, TC Action, obviously our outreach workers, folks from Reach, and a few other organizations. IPD has 2 to 3 officers that come, and a few other organizations. And and Matt, when he came on, was very helpful in putting together the list of eligible offenses that people could get into the program. And pretty much anything that wasn't violent, correct me if I'm wrong, too high of a drug crime, and that had to be pretty severe. Crimes against kids, crimes against women. Matt was willing to kind of figure out how to get most things in there so that folks who are dealing with issues around poverty, mental health, and substance use disorders could get into the program. The judges are involved in both the city and county. I actually had to tell judges they couldn't refer people to the program because it was working so well. So yes, we'll come and do a presentation this year.
Any last questions or comments? Well, again, thank you so much. You spurred a lot of things, I can tell. I can feel it. All right. We will go back to our agenda. We'll go on with our agenda. We are now up to departmental updates. Maybe we will stick with health. We have Frank Krupa from Whole Health here. Hello, Frank.
Good afternoon, everyone. I want to thank Dr. Klapek for representing the department. He's been a great advocate for the overdose prevention centers and is always a good storyteller about where we are and where we hope we can get to. Just a couple of quick updates. The Community Services Board heard some presentations from some organizations that are going to be doing some work around homelessness and support for homelessness in our county. They received grants from the Office of Mental Health at the state level. The first program was granted to Catholic Charities of Cortland, and they are partnering with an organization called RSS, who has done similar work, and they've received funding to support individuals with wraparound services as well as securing housing that are currently experiencing homelessness. They're going to be employing up to 9 individuals across 3 counties, Cortland, Tompkins, and Tioga counties. And those folks will be working with individuals that are experiencing homelessness, trying to help them secure housing. And the second grant was to Catholic Charities of Tompkins and Tioga, and they've received funding for up to 26 slots, for lack of a better way of describing it, across Cortland, Tompkins, and Tioga counties to pay for housing for individuals that are experiencing homelessness. Their program requires a mental health or substance use diagnosis. The other program does not. So we're excited about that. We don't have a lot of details yet, and I think we will likely bring them to you for a presentation about what they're doing, but we'd like to give them a little bit of time because right now they're in the conceptual phases of it, and it'll likely be several months before they even have a contract in place with the state for funding to start flowing. But at that point, we definitely want to bring them in and give you all some more detail about how the program will work in our county.
Thank you, Frank. I look forward to that presentation as the program rolls out. Any questions or comments for Frank? Okay, well, thank you very much.
Thank you.
Next up, Jared Claiborne, Veterans Services. Jared, I think you're muted.
Thank you for that. The elusive mute button.
Yes.
Good afternoon, everyone. I have nothing right now to report except that I will be participating in the point in time count, which is happening overnight, the Thursday the 25th into Friday the 26th. And I imagine Liddy, she's here, she'll be talking about it maybe later, but just for those who don't know, the point in time count is the annual census of our local homeless population, where it's a team of folks who go out in the community or around different parts of the county to try and find where people are who may be without shelter and try to get a head count of them. And that information gets turned into HUD.
Very good, thank you. Any questions or comments for JR? All right, thank you, JR.
Thank you. Take care, everyone.
You too. Next up, Lisa Monroe, County Office for the Aging.
Hi there. I don't really have a report. I just wanted to announce that our annual public hearing is scheduled. The public hearing is just a time for people to come and learn about our programs and services and also give them an opportunity to provide us feedback and, let us know of any issues affecting older adults that we aren't already aware of. And that's going to be Tuesday, February 6th at 11 o'clock at the DMB Community Church. It's also going to be recorded, and it will be on our YouTube page for people to view if they can't make it in person. So that's all I really have.
Thank you, Lisa. Questions or comments for Lisa? I will be at the public hearing. I would
Thank you.
anyway, but it's
Great.
in downtown Danby, so that makes it more convenient
Yes.
for me.
Exactly. All right. Thank you.
Thank you. Kate Shanks Booth, County Youth Services. Hello.
Hello, good afternoon, everyone. We are just wrapping up year end and getting ready for 2024. I did help co-facilitate this morning the first of two parts for our local CSEC, which is you might remember, the commercial sexual exploitation of children. We do an 8-hour training. We've had a lot of staff turnover in some of our partner agencies, so we worked with the Advocacy Center this morning. Len Stack over there and I facilitated the first part. 4 hours of an 8-hour series, which will wrap up next week. So we had about 15 people show up and really good conversation. So we're still doing that good work. And we're excited to continue with our partners to make that a resource for our youth who need it.
Thank you. Questions or comments for Kate? All right. Thank you, Kate. Next up is Liddy Barger from the Human Services Coalition. Hello, Liddy.
Hello, good afternoon. I'm here in place of Cindy, who's out today. I'm actually also homesick, so I apologize. We do not have a report at Human Services Coalition. I do want to say it's been lovely to hear the presentation today and also those funding announcements. I'm pretty excited about some of the resources that are headed into our community as far as homeless response system resources. And the point in time count, as JR mentioned, will be next week. The night of the 25th. You can get in touch with me if you have questions or want information. That's all I got. Thank you.
Great. Thank you, Liddy. Other questions or comments for Human Services Coalition? Okay. Thank you. Get better, Liddy. Okay. Next up is Advisory Board appointments. I think I got all the departments, right, that are here. Ken Clark had informed me in advance that he wasn't available today. Okay. Advisory Board appointments. We have got Josephine Karsich for the Human Rights Commission. Also for the Human Rights Commission, Peaches Gillette and Teresa Fulton. For the Community Mental Health Services Board, we have Anna Tamas, Nicole Zulu, and Kaki Wunderlich. For the Developmental Disabilities Subcommittee, we have Jeffrey Bowles and James Beaumont. And for the Substance Use Subcommittee, we have Ronald Schoeneman. So I will move those appointments. Is there anybody that would second them? Susan, thank you. Any discussion? Okay, let's have a vote then. All in favor? That is unanimous. Thank you. Comments from committee members, liaison assignment reports. Anybody have anything they wanted to share? Randy?
Yeah, we had a gentleman come visit with us a couple weeks ago about the group homes for people that are disabled. I was wondering if we could, I don't know much more about that. I did exchange emails with him, and he mentioned the Unity House was involved somehow, and I just thought maybe if we get a clarity on that. I realize you're not going to be the chair next time, but if understanding that would be helpful. And it seems to me there's maybe 8 empty houses in Tompkins County, if that's what he claimed. There were 8, now there's none. So it'd be nice to know what's going on with that. So.
Okay, I will see what I can do on that one. Anybody else? That's my thing. I missed the minute. Okay, let's do the minutes then. Does anybody want to move the minutes from December 18th? Travis moves. Amanda seconds. Any discussion of the minutes? All right, let's have a vote. All in favor? That is unanimous. Thank you. Any other business before we adjourn?
Thank you for being our chair for 2 years? 2 years. Yeah, for 2 years. It's always an interesting committee, and I think you've brought a lot of interesting things to us, so thank you, and good luck with your new chairing position.
Thank you. Well, you know, the thing about HHS is that it touches so much of what the county does in terms of employees and money and programs. And I'm always hearing new programs. I'm always hearing things that I don't know the county does. So it's not, you know, we're never going to learn all the details of everything we do. Okay, then no other business. This committee is adjourned. Thank you, everybody.